Thank you for joining me today. My name is William Reisacker, and we're going to be talking about food allergy treatment. So the topics we're going to be covering today include prevention of food allergies, avoidance, medical therapies for food allergy, desensitization, and then the holy grail of food allergy treatment is achieving oral tolerance. So on the subject of prevention, we're going to cover the maternal diet, breastfeeding, the use of hydrolyzed formulas, as well as the introduction of solid foods. So it's been found that it makes very little difference what the mother eats while she's pregnant in terms of the development of food allergies in her child. There was one study that showed that there might be a decrease in the incidence of atopic dermatitis. However, for food allergies, this has not been proven. However, it's been shown that the maternal use of antibiotics during pregnancy has been associated with an increased risk of cow's milk allergy, and this perhaps speaks to the need for biodiversity, for the bacteria that's in our gastrointestinal tract to help push our bodies away from developing food allergies. So let's talk about breastfeeding for just a moment. While the benefits of breastfeeding are indisputable, the studies have not really shown that exclusive breastfeeding has any impact on the development of food allergies. Again, there was a possible benefit in one study for food allergy, asthma, and atopic dermatitis up to 7 years of age, but it actually found that the risk was increased after 7 years of age. That said, the current NIAID guidelines recommend exclusive breastfeeding for 4 to 6 months if possible. Now, what if this is not possible? Well, we have the hydrolyzed formulas. And again, the evidence here has been conflicting. A Cochrane review found that there was no evidence support the use of hydrolyzed formulas to prevent food allergies compared to exclusive breastfeeding. Likewise, using a soy-based protein formula also demonstrated no protective effect in high-risk infants. That said, the NIAID guidelines suggest using hydrolyzed formulas in high-risk infants who cannot be exclusively breastfed. And when we say high-risk infants, what I'm referring to is infants who have a sibling and a parent who has food allergies, or an infant who has high cord blood IgE levels. So what about the introduction to solid foods? This is one example where a policy has literally been turned 180 degrees. Back in the 1980s and the 1990s, the pediatricians in the United States reasoned that, well, these foods are triggering food allergies, and food allergies are on the rise, so let's delay the development of allergies by delaying introduction to those foods. So milk should not be taken for 1 year, eggs 2 years, nuts and seafood for 3 years. This was the recommendation. However, it was found that this accelerated the development of food allergies in the United States, and other findings have been found in other countries where foods were delayed in their introduction, such as Great Britain and Australia, whereas other countries such as Israel, where kids eat peanut allergens and peanut snacks very early in life, had a very low incidence of food allergy. And there have been some very robust studies that have also showed that early exposure to foods were associated with a decreased risk of allergies. And in the corollary to this, in those two studies right at the bottom, and these were very large birth cohort studies that actually showed that delayed introduction of solid foods were associated with an increased risk for food allergies. So with this, a study was undertaken. So this is the LEAP study. This was in 4 to 11-month-old children with severe eczema, egg allergy, or both. This was an open-label study that was performed in the UK. It was done for 60 months using either peanut consumption or avoidance, and they stratified this into kids who had a positive skin prick reaction and a negative, but in both groups there was an overwhelming benefit to early consumption for peanut allergen. And this was the final blow to that original policy on delaying foods, and now early introduction is the recommendation. So what do we do now? Well, the Leap On study was performed, and this was based on many of the patients who were in the original Leap study. What they did was a 12-month avoidance period after the early introduction, and they found that the peanut allergy rate did not increase, so there was a durable benefit from the early introduction. There was no effect on the duration of breastfeeding. There was no negative impact on growth or nutrition. So it appears that there is a valuable window of opportunity around 4 to 6 months of age where it's actually very important for your body to start seeing these foods in the oral cavity. The oral cavity is really the classroom, the place where our body gets educated about which foods it needs to be exposed to. And this makes a lot of sense because this is when breastfeeding probably naturally trailed off in our human history. Now, how do we apply this LEAP criterion in the real-world setting? Certainly, it's not cost-effective to screen every child before introducing these foods. However, with children with severe eczema, egg allergy, or both, it is strongly considered to do some testing prior to introducing at the 4 to 6 month mark. If they only have mild to moderate eczema, then you can introduce the peanut-containing foods around 6 months. And if they have no history of eczema or food allergy, you can introduce the peanut-containing foods as your family and cultural preferences dictate. So avoidance of food allergens really is about avoidance of nutritional deficiencies. If you're having a child decrease their exposure to dairy, for example, you have to consider that some of those elements are very important, such as the calcium, which is important for bone development, or the fats that are in dairy products that are helpful for development of the central nervous system. Of course, there's strict elimination for any immediate or severe IgA-mediated food allergies. Elimination diets have been found to be helpful in managing atopic dermatitis as well when that person was also food sensitized. Amino acid-based formulas have also been found to be effective in children with EOE. This was originally thought to be related to food allergy in the esophagus. However, now the thinking is that the amino acid-based formulation may actually just give a period of gut rest, essentially, and that is helpful in reducing the inflammatory reaction there. And then the controversy about when to reintroduce allergic foods, it's always a big question. Certainly if the in vitro testing converts to negative, you can consider this if the patient has non-immediate or non-severe life-threatening reactions, and after the completion of therapy, such as with EOE. So reading labels, this is very important, and this is very stressful if you think about it from not only the patient, but the parent of a child who has food allergies. Thankfully, it has been made easier in recent years with the Food Allergy Labeling and Consumer Protection Act of 2004. So the big allergens are now labeled as containing those ingredients. However, there's no regulation on advisory labels. About 5% of those advisory labels that have the may contain warning actually do contain that ingredient, and that's been found in a fairly large study. It's important when you're looking at the ingredients to recognize prefixes. So Ovaltine, for example, if you look at ova, that means egg, and you wouldn't naturally think that Ovaltine is a significant source of egg, but understanding that prefix will help you understand that. Also, some hidden sources of foods, for example, oftentimes Asian restaurants will seal their egg rolls with peanut butter before frying, and this is something that can really affect your patient. Here are some examples of hidden sources of foods which really hit home for me. On the left, this was a beer that I had consumed after a meeting in San Diego a couple of years ago, thankfully with no untoward results. But a person who is highly sensitive to peanut could be in for quite a surprise if they go out for a beer. So the Food Allergen Labeling and Consumer Protection Act in 2004 made it a lot easier for people who were trying to identify which foods were in which products. And the labeling is for the 8 big allergens: milk, eggs, fish, shellfish, tree nuts, peanuts, wheat, and soybeans. And you can see also that in most of these allergens, the incidence decreases going from childhood to adulthood, except for shellfish and tree nuts. It's also important to understand where the high-risk areas are. Accidental exposures occur very commonly. even during a 5 or 10-year period. Some high-risk areas include Asian restaurants, bakeries, ice cream shops, airplanes, birthday parties. It's been found that half of the fatalities have occurred in schools and in restaurants. And in the majority of fatal reactions to food allergens, the person knew what they were allergic to. So let's talk a little bit about the medical therapies. These are the allergen non-specific therapies, including epinephrine, dietary patterns and supplementation, and biologics. So epinephrine, one of the most important tools in our toolbox, particularly when taking care of allergic patients who have food allergies. Food allergy is the most common cause for anaphylaxis. Education is key here. You want to teach the patients about not only carrying the EpiPen, but how to use it, and train families as well. And this is difficult because many people forget to carry it. They don't want to carry it. But parental training does increase the odds of having it available. Unfortunately, even when everything is done right, the outcome isn't always favorable. Among anaphylaxis fatalities, 14% had early and repeated administration of the medication. The 3 cardinal rules with epinephrine, just like tracheotomy: when you think epi, use epi. Once the unit clicks on the side of the thigh, you want to count to 10. That's because the medication is still being delivered. Some of the newer units, like RVQ, have decreased that time to 5 seconds. And also, it's important that they call 911 after they give the dose. You don't want to have the patient hanging on the phone talking to 911 while all the while an anaphylactic reaction is developing. So a Mediterranean diet has been associated with a decrease in asthma, allergic rhinitis, as well as weight. However, its impact in food allergies has not been as dramatic. This is a diet that's rich in polyunsaturated fats, fish, fruit, veggies. Now, the impact of probiotics possibly may be helpful in atopic dermatitis, but even for this, the data is not strong. However, probiotics have been used in the food allergy arena along with peanut oral immunotherapy, and this is going to be discussed in a few slides. It's been beneficial to help maintain sustained unreactivity, or SU. Now, what about the role for antioxidants, folate, vitamin D? Well, here the data has been very conflicting. They found that neonatal vitamin A supplementation is actually associated with atopy, along with maternal vitamin D supplementation during lactation. It's been found to be associated with an increased risk of food allergy. Currently, there's a study going on in Australia, which again is looking at vitamin D supplementation during the first year of life. This is the Vitality study. Now, what about the benefit of using biologics? Let's look at omalizumab, or anti-IgE. We discussed this in another presentation with regards for treating allergic asthma, but what benefit does it have for food allergies? Well, they've tried this alone for food allergies, and a phase 2 study had to be canceled due to adverse events. However, currently, omalizumab is being studied as a pre- or co-treatment along with oral immunotherapy, and this is in phase 2 trials. Now, mepolizumab, or anti-IL-5, which decreases the stimulation of eosinophils. This has also been used in patients with eosinophilic esophagitis, which is thought to have some association with food allergy as well. And while it was found to decrease the number of eosinophils in the esophagus, there was limited clinical benefit. What about the toll-like receptor antagonists? Well, this skews the system away from the Th2 response. These are pattern recognition receptors, and early work has shown promise in animal models. So now let's focus our attention on desensitization or allergen-specific therapies, and that includes subcutaneous immunotherapy, sublingual immunotherapy, oral immunotherapy, and epicutaneous immunotherapy. So when was immunotherapy first studied for its use in food allergy? Well, there was a study in the 1990s using aqueous peanut extract using a rush escalation schedule. And while tolerance was induced in the majority of patients, the systemic reactions were very high, making this a very impractical solution for food allergy and not useful in clinical practice. And even more so, it really stopped all talk of immunotherapy for food allergy for the next 10 years almost. Now, there is some potential collateral benefit from just doing aeroallergen immunotherapy. we've spoken before about the pollen food syndrome, where patients who are sensitized to birch tree can also react to apple. Well, the corollary is true, is that subcutaneous immunotherapy for birch pollen can potentially decrease the reactivity for the food allergens that are in apple after about a year of therapy. So almost 10 years after that aqueous peanut extract study, people started talking again about immunotherapy for food allergies, and they spoke about it using sublingual immunotherapy. This was first studied in hazelnut allergy. However, benefits have been found for other foods such as milk, kiwi, peach, and peanut. So what about sublingual immunotherapy for peanut allergy, which is kind of the holy grail of allergy? There have been a few studies which have demonstrated that there is tolerance developed for peanut. Burks in 2015 found that 10% developed a sustained tolerance over a 3-year period of time. Unfortunately, 50% of the patients eventually withdrew from the treatment, possibly because sublingual immunotherapy just doesn't really fit well into a person's day-to-day routine. Now let's talk about oral immunotherapy, or OIT. This is something you've probably been hearing about. You've been reading in the literature, and you even heard in the articles in the newspaper. What this is a protein powder that contains the food allergen, and it's mixed with some sort of a vehicle food. This is using rapid escalation, so a very quick escalation period, and then a variable maintenance period, sometimes 6 months, sometimes a year. And oral desensitization and tolerance has been described for multiple allergens. Now, we talk about desensitization, we talk about tolerance. What is the difference between those two words? Well, desensitization means that while you're receiving the therapy, you're able to eat more of that food without having a reaction. When we say a person is tolerant, that means that even after the treatment has stopped over a period of time, the patient is still able to eat that food without having a reaction. Then we say they've become tolerant. So this has been found to be very helpful. The only problem with oral immunotherapy is that the adverse events are very common, particularly during the escalation phase. One study showed that there was a 92% rate of adverse reactions. So in summary, for oral immunotherapy, a very effective therapy, however, possibly too dangerous to do in clinical practice. The other problem with oral immunotherapy is that we're not sure really how long it has to be continued. Many of these studies have gone for 6 months or have gone through a year. However, if the person stops eating that food, it is not continually eating the food after the study is done, could that tolerance eventually wear off over time? That could also be potentially dangerous for a person to think that they're tolerant to a food and actually be vulnerable to it. So oral immunotherapy for peanuts, again, the holy grail for food allergies. And there was a couple of studies that showed both for single food as well as multi-food OIT that this was a very effective treatment and tolerance was being achieved. Now, what about sublingual versus oral immunotherapy? Well, for milk, there was some indication that in terms of oral food challenge, that more of the patients who are on oral immunotherapy passed this versus the sublingual immunotherapy patients. But if you look at the daily maintenance dose for oral immunotherapy, we're talking a couple of grams daily maintenance, while sublingual immunotherapy has a very small dosage in the milligram dosage range. The reason for this being, with sublingual immunotherapy, we're using liquid extracts of these foods, and it's just difficult to get a large concentration of that protein into the oral cavity. You would have to do doses that were too large to hold under the tongue, or you would have to do dosage 3 or perhaps even 4 times per day, and that's very difficult for patients to do. So looking at peanut allergy, SLIT versus OIT, there was a lower cumulative threshold in SLIT after 1 year, meaning that it didn't take as much to produce a reaction in the sublingual patients compared to the oral immunotherapy. But if you look at a 10-fold increase in threshold dose, then sublingual seemed to be about the same as OIT. And the same thing with milk. The maintenance doses for OIT are sometimes 1,000 times higher compared to SLIT. Now, what about using both together, perhaps? There's been some talk and some studying of initiation of therapy with sublingual immunotherapy, and then a stepwise progression to oral immunotherapy. And this has been found to actually decrease the number of adverse events during the OIT phase. So let's talk a little bit about epicutaneous immunotherapy. This involves disruption of the stratum corneum, and this allows penetration of antigens into the epidermis where it can gain access to the Langerhans cells. And this can be done either by excoriating the skin or by applying a patch, which is basically a humidity chamber, and that humidity actually breaks down the stratum corneum. This has been found to be effective for food allergies in the animal model, and there's also been some success with airborne allergy, grass allergy in human trials. Now, there was a trial with children with cow's milk allergy, and this demonstrated desensitization. And there are ongoing studies now, both in North America and in Europe, using epicutaneous immunotherapy for peanut allergy as well. So this is one group out of France, DBV, which has produced the Viaskin peanut patch. Phase 1 studies were very promising. However, treatment emergent adverse events were fairly high. Almost 50% of the patients had at least one non-local reaction. So this was away from the site of the actual patch. But there was at least one local adverse event in 84% of the peanut group and even 60% in the placebo group. So what about the effectiveness of the Viaskin peanut patch? Well, there are a couple of studies that were performed that show that there was efficacy of this, and they had studied a couple of different dosages, particularly the 250 milligram and the 100 milligram dose. Jones in 2016 demonstrated that success for the Viaskin 250 was 62% for ages 4 through 11, but over the age of 11, only 14% successful. And recently, a phase 3 study was performed, and this failed to achieve its primary endpoint. And they were using the 250 milligram dose. The difference between the active group and the placebo was less than 15%. So whether or not this patch gets on the market, we'll have to see. Stay tuned. So future directions for food allergy, we're going to talk a little bit about peptide immunotherapy, recombinant allergens, immunostimulatory adjuvants, and then some other allergen modifications. So what is peptide immunotherapy? Well, peptide immunotherapy uses synthetic peptides which contain the B or T cell epitopes, but without the IgE binding epitopes. So in other words, B and T cells can recognize the protein, but the IgE molecules cannot. And this potentially is going to give a safer allergen for immunotherapy. This can be produced in a very standardized fashion. And these proteins can also be combined with other immunostimulatory agents. Late phase reactions have been found to be a bit problematic, and there are preclinical studies that are going on right now for egg, milk, peanut, and fish. Now, recombinant allergens, these are purified allergens, and these are made from allergen-encoded DNA. And this comes in really two varieties, the native or the wild-type allergens, which solve the problem of supply and standardization as well as quality control. And this is available for some airborne allergens like birch tree pollen and timothy grass. And there's also the hypoallergens, or the genetically modified allergens. And this uses site-directed mutagenesis to actually decrease the IgE reactivity. Just like with the peptide immunotherapy, you're not allowing the IgE to bind to the protein as easily, and this potentially can give a safer protein used for immunotherapy. So this has been developed for peanut allergen, and some phase 1 trials are underway currently for their use in subcutaneous immunotherapy. So who knew? Now we're talking again about a subcutaneous immunotherapy for peanut allergen again. Also, some other foods like mango, peach, and apple have been studied. And there are also studies going on using a hypoallergenic recombinant parvalbumin allergen. This is a fish allergy. This was developed from carp. And this has been used for subcutaneous immunotherapy for fish allergies. And we have phase 1, phase 2 studies have already been completed, and we'll probably be hearing more about that in the years to come. What about immunostimulatory adjuvants? So these are agents that can be added to the allergen to make it more likely to go towards that Th1 phenotype and away from the Th2 phenotype. This can be used with viral carrier proteins using measles. or bacterial products with immunotherapy. There was a phase 1 study using recombinant peanut allergen. This was encapsulated in a heat-killed E. coli, and this was actually used with rectal immunotherapy. You think your research is a pain in the ass. Unfortunately, these studies were stopped because of high rate of adverse reactions. Also, heat-killed listeria has also been used with that Th1 skewing effect. So what about some other allergen modifications? Well, antigens can be attached to the surface of splenic leukocytes, and that's been found to induce tolerance. Also, nanoparticles containing peanut allergen have also been used in the murine model. Now, changing the allergen somewhat by boiling the peanuts or gamma irradiation, that could potentially alter the protein enough so that the T and the B cells are able to recognize it, but the IgE is not able to recognize it as well. Also, pressured denaturization of 3D protein structures, and incorporating extensively heated egg and milk products into the diet, which pretty much describes me making brunch for my family. So as you can see, there are a lot of exciting advances that are occurring in the arena of food allergy treatment. So keep your ears open, and you're going to hear a lot of information coming up in the future. So thanks for joining me today.